Okay. I think we're there. Sweet. Okay. Only took an hour and 45 minutes, but
That's okay. That's okay. We're all learning together. Can they hear me? Will anybody pop up and say yes?
they
Okay, here right now.
So, I guess I'll just continue, and they'll let you know if they can hear me or not. This is going to be a cardiology review. My name is Jessica Ross. I am a nurse for Survival Flight. I have been flying on the fixed wing for a year and a couple of months, and I've been flying on the helicopter since 2018. I transitioned to Survival Flight in 2021, so I've been with the company for 4 years. So this is going to be kind of a refresher.
I got you down there.
Thank you. 101 okay.
Okay. So there'll just be some essential knowledge. It's going to be a refresher for some people. Kind of the basics of cardiology. We'll go over some ACLS drugs and we'll get right into it. The disclaimer here just says that we're giving this lecture in good faith. This is hopefully the most up-to-date best care practices. There's not any conflicts of interest, financial relations, or other associations to disclose. So today's session will begin with a review of the basic anatomy and physiology of the heart. Then we'll follow that up with a discussion of common cardiac emergencies and conditions. We'll look at those ACLS protocols and kind of explore some diagnostic tools and essential pharmacology. You're listening. First, we'll take a look at the basic anatomy and physiology of the heart. Understanding the heart structure is vital to an effective response. Whenever someone calls for a cardiac emergency, we're going to look how it supports the circulation of the entire body as well. So we all know the structure of the heart has 4 chambers, 2 atria right and left, and 2 ventricles right and left. There are valves in there that help to regulate the blood flow. There's electrical nodes, and take a look at that. But all of these working together is essential for a good cardiac function. So the cardiac cycle, you've got the systole and the diastole. Whenever you're in systole, that's the contraction, and then the diastole is a relaxation, and that is crucial for an effective blood flow. Understanding these phases can help us interpret and recognize things on our EKG. Whenever we go out and go for a chest pain patient, we want to be able to recognize, there's a STEMI or a block or any of those other disorganized rhythms present. So distracted, so
You're
easy.
fine.
I'm sorry, guys.
You're doing good.
I keep hearing these tones go off, and I'm like, oh, where's my flight suit? I gotta go.
Well, the camera's not on you, so they don't know. They're none the wiser. So,
well, I'm trying to listen to the radio and talk at the same time, so my brain,
You are not on shift.
yeah, no.
Not our call.
If y'all see me take off running, I'll be back. There's not a helicopter outside.
I've learned I'm on one of the fire departments close to our house, and I'll keep the radio on to listen to traffic. Well, at night I have to put it on pager because I don't want to get used to that sound and get to work
and be able to sleep through it.
Yeah.
So I think we all understand the struggle I'm struggling with right now. Every time that pager goes off, I'm trying to get up and run. So, but we're gonna get through this cardiac together. So just more of a look at the electrical system. The SA node is our intrinsic pacemaker. It causes the natural heart rate. We want it 60 to 100 beats per minute. Then the AV node It's a little bit slower, but it's also kind of the gatekeeper. It slows down that impulse before it reaches the SA node. And then whenever we are out there getting those EKGs, we have to be able to identify electrical dysfunctions because it's crucial for diagnosing several conditions. Okay, so some cardiac emergencies, we'll look at some of those and look at what is required to be able to identify those and intervene appropriately. And then we'll talk about some common conditions that we're going to encounter in the field with our pre-hospital treatment. So we've all picked up that lovely STEMI patient. You get out there, they call for chest pain, they might be sweaty, diaphoretic, pale. They might have pain that extends down their arm up into their jaw. This is due to an obstruction of blood flow in the veins and the vessels around the heart. So being able to recognize that and get an EKG quickly is crucial for caring for our patients in the field. And then also give them the morphine or fentanyl, oxygen, nitro if it's indicated, if it's not like an inferior MI, and then the aspirin, and make sure that we're transporting these patients to an appropriate PCI facility.
And Mike asked a good question here just a little bit ago about our flight criteria. If you guys go to a place that you are just getting paged out and all they've told you is the patient's having chest pain and you already know it's going to take you a minute to get there, not to mention how long it's going to take you to get them to Baxter or to West Plains, because those are y'all, is PCI at West Plains too?
Yes.
Okay, so those are your two closest. You guys can always call for an aircraft. You can call your dispatch, tell them, go ahead and launch them. And that way they can already be out there. If not, they may even beat you out there. And that way that at least gets that time started, because the goal is getting them into that cath lab time. So that is a criteria that we will fly for, distance and time. Yes. You know, if it saves the time for that patient, or if it's too long of a distance for you guys to travel without decreasing your resources. And you guys run 2 trucks in the county. That's it. So you take 2102 out, you guys are already depleted your resources. So that is a reason to call us.
Yeah, absolutely. And you can always launch us. And if you get there and you're like, oh, well, this is, maybe dispatch, you got some conflicting information, you get there and you don't really think that a helicopter is needed, or they are, refusing transport or whatever, you can always cancel us.
And we would much rather be in the air, en route to you and get canceled than sitting at the base waiting, because again, that time sensitive thing for your patients, even stroke patients, that's time sensitive. I'd rather be more than halfway there and you guys say, hey, never mind, I don't need you. Yeah. Then you guys get there and say, oh yeah, we do need you. And now we're behind the 8 ball.
Yeah. Thank you.
Mm-hmm.
So what would be what would be good examples of that if we're, because we're relatively an hour from any facility here. So
if you call dispatch and they could say that we can be at your scene in 30 minutes,
yeah,
that's already saving you that time.
Yeah.
So because honestly, from Pocahontas itself to Baxter, it's less than an hour. In flight. So, and that's just us. You've still got West Plains. So you got West Plains and Mountain Home that also have aircraft. Granted, it's airback, but it's still an aircraft. And they are still the same type of thing. It is time sensitive. I don't care if it's me, airback, or whoever. It's what's in the best interest of your patient.
Right.
Who can get that patient where they belong the fastest and the safest.
Yes. Yeah. So, sometimes your patient, it could be a presentation like a STEMI. They could be complaining of chest pain, but it is not showing up as a STEMI on your EKG. you still wanna do that good cardiac assessment. You may even end up giving them aspirin and or nitro, oxygen, you know, the whole MONA acronym. But they might not have the ST elevation that you typically see with a STEMI. So they still would oftentimes require transport, and the reason for the pain needs to be investigated by a cardiologist.
I don't know if I heard you say, but some of the physicians, some of the cardiologists are going more to FONA and doing fentanyl versus morphine, because a lot of people have reactions or sensitivities to the morphine. The morphine is also more of a respiratory depressant, plus it is a lot harder on the blood pressure, as fentanyl is not as hemodynamically unstable. So we prefer in the flight world to use our fentanyl versus our morphine unless there's a real big contraindication.
And like she was saying, you have less hemodynamic instability with the fentanyl. The fentanyl also has a shorter half-life. So if you do get any hemodynamic instability from that just opioid narcotic administration, it's going to be shorter lived with the fentanyl versus the morphine.
Yeah. Well, I found too that it seems like less people get nauseated on fentanyl as opposed to morphine.
I agree
Have
with
you
that
noticed that too?
Yeah, and that's another good thing to bring up. When it comes, they will have the nausea, and they may or may not have already vomited. So treat for that in the field. They might not mention it because they might be hurting so badly. So be sure and ask them, you know, if they're hurting or if they're having nausea as well, and you can treat that and save yourself a little bit of a mess. The next slide here, it kind of talks about congestive heart failure. You can see some of the signs and symptoms of heart failure. They can have that chest pain during exertion. They'll have shortness of breath, dyspnea. They might be dizzy, or you could observe swelling, especially in their periphery, like their hands and feet. They could complain of a weight gain over the last couple of days. It would be significant, you know, 4 to 5 pounds. That's a pretty big jump in a couple of days. And they're going to have that fatigue because they're not able to exchange oxygen as well. So they're not able to pump out the blood.
What do you guys have on the truck now as far as positive in non-invasive positive pressure?
Are you using CPAP?
Okay.
Yeah. So that
So
is,
you do have something.
yeah, that's generally, that's a good way to support someone if they are having a CHF exacerbation and they need some of that positive pressure to help support their respirations. So we're having a pump issue. We're not able to get the fluid off so that we can effectively, so that our heart's pumping effectively. So if we can support that with the positive pressure and help open up that alveoli, they can have more oxygen exchange. So we all know ACLS. Whenever I was making this, I decided that I would include the ACLS drugs, and we can talk about them a little bit, and so that we can refamiliarize ourselves and make sure, because everybody, I definitely have to refresh myself on that sometimes. If it's been a while since I've read a code or treated, you know, VTAC or whatever, and we want to make sure that we stay up to date with that.
And there's nothing wrong with it. I actually went and picked up a BiPAP patient the other day, and it's been a year since I messed with our BiPAP. So I'm calling just as I'm walking in, saying, hey, let's run through this real quick.
Yeah. Adrian.
So there's nothing wrong
definitely.
with double checking and knowing, you know, because
Yes.
again, we all get rusty
Yeah.
if we haven't touched it in a year.
Well, we were actually discussing during the pediatric portion this morning that, you know, they hammer in pounds and ACLS, like your drug dosages.
Yeah.
And Tim was like, well, you know, that's really, he's like, don't memorize those because you're going to make a mistake. Refer back to your
Yeah.
your PD wheel or your Braslow tape. And it's funny, but they just hammer into you. You gotta know these, you gotta know these, you gotta know these, and there's no possible way.
No,
No.
there's not. And,
Separated.
keep in mind that the PALS and ACLs and everything changes their stuff,
Yeah.
so you need to rotate out your Brazlo tapes. I didn't realize that we had several that were
They're
the
dated.
older ones. They're
Yeah.
like, hey, we need to
We
order
replaced
our
ours
updated
last
ones.
year.
Yep.
Yeah.
I think the newest one they have is the 2023.
It is.
And so that's something to make sure of whenever you're doing your checkoffs and checkoffs and stuff, and then make sure all your equipment and everything, including your tape, is up to date.
Mhm.
So that's
We
good,
were
y'all.
Disgusting too. We don't even have like the name, the brand Brazlo. It's like the Wish version.
Oh, yeah, no, we have the PD tape.
Do you?
Yeah. It's called
I think that's what
Yes,
we have.
that's exactly what it is.
Yeah.
Yeah. I have the very photographic memory that doesn't serve me for anything except random.
And of course, they have your app versions. They have the PD help
Mhm.
and everything. Granted, if you don't get in there and use it before you get your patient, it's not gonna be helpful.
Yeah.
Oh.
So, I mean, it is definitely one of those not super
Mike was
user
suggesting
friendly.
it.
It is really good,
love
but
it. Yeah.
you got to get in
Yeah.
there and use it well before you have a patient, because otherwise it's not that user friendly to just, hey, first time user, you're just jumping in and putting stuff
Oh.
in. You'll want to play with it some before you
Okay.
actually use it.
Okay. He said it's like 99 cents.
Yeah, it's super cheap.
Okay.
Super cheap.
Yeah. If you wanna go to there, if you
Oh,
want.
nice.
Yeah. So I do recommend the PD Help app,
Mhm.
and that has a 10 kilogram patient in there. You can change your weights and all that stuff, and it'll give you the dosages and stuff. So back over here to our cardiac stuff. It's so important for us to have a quick recognition of a person who might be having cardiac arrest here, but any kind of cardiac emergency, we need to be able to recognize that quickly. So whenever we get on scene, we want to get, the monitors on them, evaluate their heart rhythm, look at their blood pressure, their pulse ox, are they perfusing? Do y'all monitor internal CO2? Yeah, so that's a great resource for looking at your
What-
perfusion.
What monitors do you guys have on the trucks now?
15. Okay.
Like packs?
Yeah, those are big.
Yeah.
They're just so heavy.
They are heavy. A lot better than what we used to have.
So, you want to activate all of your appropriate responses. Do y'all call in and activate the cath lab if y'all are bringing in a STEMI?
I did last time, when we went to Baxter, we picked up from scene and went straight to Baxter, and it was about a 45-minute trip, and I think I called, probably about 35 minutes out.
Yeah, so
When
they
I
could
had-
get
Yeah,
their personnel.
when I had cell service, and I was actually disappointed. I mean, the ER staff was great. They got in there, they got x-rays, they got labs, they got all the things that they needed. And it took, cath lab another hour.
Really?
Yeah.
They have someone on their table.
No, it was trying to call everybody in. It was like 11 o'clock at night, I think, 10 or 11 o'clock. But, and like the charge nurse was really upset too. She's like, there's no excuse.
Yeah,
Like you
there's a
called,
break.
yeah, you called enough out. Yeah.
Do you guys have to use or have the access to use Pulsar?
We're getting it.
How do you, okay, so you haven't used it yet.
No, well, I played with it.
Okay.
It's
What,
coming.
have you used it at all?
Not on anything that.
I'm just interested to hear the EMS side of their feelings, because personally, using it in the aircraft, and if I'm super busy, that thing's not user friendly. I would much rather be using my radio call and report
Yeah.
telling you what I got than sitting here on an app trying to fill in all this information, taking a picture of an EKG and sending it in. And especially if you're in the back of the truck and you're by yourself. So when you guys get it, you may play around with it before you go with an actual patient with it and decide, is this something that I can do while I'm taking care of my patient, or do I need to grab a first responder
Well,
or
the
somebody to go with
nurse,
me?
one of the nurses at Baxter, actually, he kind of showed me a shortcut on that a lot of y'all's employees do, is they just take a picture of, like, they put the name in and like the date of birth, and then they just take a picture of the monitor.
They don't fill the rest of the stuff out. maybe that's what it is. If we didn't get
Yeah.
really good training on it, it was just, hey, they want us to start using Pulsar. So when you open it and it has all these boxes to
Yeah.
fill in, it's like, so I gotta fill all this in, especially as a nurse, because a nurse, we're like, we gotta fill every hole in.
Yeah.
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 So, okay, well, if that's all they're requiring, then that may not be that.
Now,
way.
now depending on facility, I mean, because
Mhm.
you've got, expectations on certain people when they come in that, Allison is held to a higher standard. So if she took a screenshot of a monitor, put name and date of birth, they'd probably be like, well, what's the nature of a call, or, this, that, or the other, as opposed to somebody else.
Yeah.
If it was a
So-
Sarah with going to Baxter, I think they would be like, oh yeah, she's trying really hard to do not a ton, so she can focus on the patient.
Okay,
So I told
okay.
them multiple times, like, this is not community.
Okay.
Well, we have to use it.
So you set the bar low, is that what you're
I
saying?
did set the bar very low.
So
So
which-
all my ENT did it for me.
It sounds like though Arkansas is pushing to do that when it comes to the system, because Little Rock's, several of their facilities are doing it for stroke alerts, trauma alerts, and STEMI. So now let's talk about the trauma. If we're doing a traumatic trauma, I mean, we can say, we're gonna talk about some cardiac trauma stuff, but if you have that traumatic event, are you gonna have time?
No.
That's not,
Well, and you're talking about your first responders, and I mean, you guys know I love my guys. I mean,
Oh, yeah.
I really work with them. But let's just be honest, they're older. So when you shove a tablet in their
Yeah.
face and say, I need you to
That's
fill this out. Now, Bernard would be fine. Bernard would be
I'll be
great.
honest, in Mountain Home,
Yeah.
there's some young guys in the fire department. I
Yeah.
handed them a tablet one day and he looks at me like, how do I do this? And I'm like, you're 18, like, just punch on the thing.
but that may be some of the
So-
things that we may just need to start thinking about.
Yeah.
I mean, in the next
You're
5 to
right.
10 years.
Yeah.
Do we need to start, when we do our outreach educations, do we need to be like, hey, guys, let's go over some of these things that I may ask you to come help me with
Yeah.
when I'm on scene.
So do you think Sarah will be around?
I think Pulsar is the push. I know Batesville's helicopter, whenever they fly into Little Rock, whether it is a trauma, stroke, STEMI, or even some of their just regular reports, like in their facilities, they're using Pulsera because that's what the facility wants.
It's international, I believe.
Mhm.
It-
It's
That
gonna be
lady that we
mandated.
talked to was out of Florida, wasn't it?
Yeah, it's gonna be mandated.
And I wonder, is that because of the A-Win radius? Because they're pushing for us to get A-Wins. And if it's such a financial thing for them to transition everybody to A-Win,
Mhm.
that maybe this is their workaround.
Yeah, and I think some of it has to do with like patient tracking and, outcomes versus, your early recognition and.
But how many damn patient like, you've got your stroke, you've got your trauma, you've got your documentation in the system, and it goes out everywhere, the state system. How much do you need?
Yeah, because they used to have personnel for that internally.
Yeah.
With facilities, and I don't know if it's more of a reach to cut out that,
The
that
middleman.
position.
Okay.
because
But
you don't
I
have to do
think
chart
for
abstract.
us on the ground is just being aware that it's coming and then just making note of it. So when we do have things, conferences come up, we can bring up the concerns of, hey, this isn't working. You know, just like ACLS
Yeah.
changes every 5 years because they realize, oh, this isn't working,
Yeah, and it takes a while for the published interventions to catch up with the data, and then the data changes again, and they change the interventions, and it's just so fluid, it all just goes back to what it was, and it's like a cycle. But maybe with the Pulsera, it would be a good idea to start incorporating that with like case studies and stuff when we're doing our education,
Yeah.
bringing that, and you can do a fake chart, a sample chart, and make sure everybody knows the input.
That's a good,
Well, one of my biggest questions with Pulsera is the bigger cities in Arkansas that have fire medics. When a fire department like Springdale, Rogers, Bentonville, when they get dispatched to a call, they have 5 people on scene.
Yeah.
So you can hand the tablet to
To
the
have
captain.
someone.
Whereas, what about on EMS? I'd be interested to see how Central Path or NIMS is handling it. Because if they're only running 2 people in their ALS rig, they're at a disadvantage, whereas the fire team. But if they're running with firefighters, like Fayetteville doesn't run their own ambulance like Springdale does, would be interesting is Fayetteville being handed a tablet and Central's doing the stuff.
Yeah.
And Fayetteville's like, all right, you're in.
So even
See ya.
your air crews, I mean,
Yeah.
we may have 2 of us in the back, But if we got a critical patient, we're both hands-on.
Exactly.
We're
Yeah.
busy.
Yeah.
My tablet might end up
Be like,
covered
I
in
don't care
blood.
about that
Yeah.
tablet.
Ask me
You
how
can
I
throw it
know.
out the
Yeah,
window.
shove it to the pilot and say, here.
Yeah. Drop this in there. Yeah.
Just put it on autopilot. It'll be okay.
Yeah.
So just some things that are probably coming down the line that we need to be aware that, no, we don't have the blessings of being in the big cities and lots of extra resources. It is you and your partner. So how does it work? Can it be worked? And if it's not doable, then making sure you have that communication with your facilities that you're gonna be going to and say, hey, listen, this isn't working for us. Can I radio it in and maybe your nurse that's taking a report, plug it into the system?
Well, being in a rural area is a Pandora's box, because you can always use the excuse of we didn't have service.
Yeah.
That's true.
Which
And
half
that
the time
happens
is
with
true.
aircraft too,
There's
yes.
spots between Tyler
Yeah.
and Jeep that I don't have service.
Yeah,
And it's free, but it's enough to keep
Yeah.
you off the internet.
yeah. Well,
Yeah,
if you
so-
watch in between Salem and Viola, there's one too.
Oh, is there really?
If you look on the England radio too, also there's a big spot over there.
Yeah,
Interesting.
Out of
Yeah.
range.
the Bermuda Triangle is the Djibouti.
We know where that's at.
That's just the Pulsera and all that. Just be mindful that there is a push for using that, and but whenever it comes down to it, we just go back to what we know how to do, how to interview for patients, and electronics can come second. Of course, we have defibrillators. What rhythms do we want early defibrillation for?
VFib.
And any ventriculars
Yeah.
without pulses.
Yeah, pulseless VTAC and VFib. Okay. And I've heard some trials of defibrillating asystole. They're kind of classifying it as a fine VFib. I haven't heard any of the outcomes of that.
No, say that again?
Does it have to be witnessed?
There's some,
I haven't heard any of the outcomes. I don't know if it's witnessed. I can't recall exactly, but that was floating around at one of the conferences I went to.
What is recognized as VFib?
It's a super fine
Fine,
VFib.
Oh,
They're, well, it might have been asystole, especially if it
Oh,
was persistent.
yeah.
But they're.
So they're bringing that back, because ACLS used to be that way.
Yeah.
Because I
I've
remember
heard that
on the
they are.
pre-test,
Yeah.
that you
Yes.
had the
Yes.
asystole or the fine
Yeah.
VFib, and it would get you
Every
every
single
single time.
with your
Yeah.
rhythm recognition.
Yeah.
Yeah.
Sure would.
So, but we all know how to use our defibrillators. IEDs are becoming more common, in like churches, community centers, probably even Walmart, and,
You know what that says to me, thinking about this? Bad information.
I don't know who that is. That's a new name.
So to me, that sounds like fine VFib, possible asystole, because we're not going back to the golden days when you used to shock asystole, but
Oh, no.
there might be a possibility
Some
that it's
never change,
VFib.
y'all.
right.
So go ahead and try to defib it.
And it's kind of like, well, they're not gonna get any data.
Yeah, yeah.
Yeah.
Yeah, so, so just keep that in mind, and, if your schools and churches, community centers, all that, if you have an emergency come about, we definitely wanna, ask them, do you have an AED, and everyone, they're pretty much self-explanatory, so if you could use a defibrillator and synchronize and unsynchronized and do all that upper level stuff, you can use an AED. So,
Just be sure that you turn it on.
yes, once you
Hit
turn it
the
on, it will
power
tell you
button.
all the thing, yes.
Or if you're synchronizing, make sure you have
Have that
marks.
little So, all right, we'll take a look at our medications. We've got our Epi, Amio, Lotto,
I like
it
that.
came back, yeah. So,
I'm probably gonna be stealing that, by the
yeah,
way.
that's fine.
That is
Perfectly
awesome.
fine.
Yeah.
That is
Very
terrific.
good, thank you. I'm
Actually,
a weird passion for.
we were
making
texting back and forth, and we
medications.
looked at it, I'm like, these are some things that are really good. We're gonna give this to our new clinicians that are coming on. and-
Yeah.
So this is just like a quick overview. And then we can dig into each one of these medications specifically.
Maybe I can put that in the group chat.
Yes.
Okay.
Alright, so for our epi, we're gonna use that for cardiac arrest, whether that's asystole, VFib, pulsus VTach, PEA, that's the only medication you can really use on here, PEA. If you have a patient who is bradycardic and they're not responding to atropine and or pacing, or maybe they need a little more response, then that might be when you want to give them a little epi drip to go along with their other interventions. Of course, our anaphylaxis is not ACLS specific, but we always want to be able to recognize that. And we also use our epi for anaphylaxis. That's it, an IM dose. And for cardiac arrest, it's 1 milligram every 3 to 5 minutes. So you want to make sure that your recorder knows when your epi has been administered and make sure that they know to kind of notify you or whoever's running the code whenever it's been a couple of minutes. And whenever, if we're doing the infusion, we can do 2 to 20 mics per minute and titrate that to your desired effect. Our amiodarone, that's what we'll give for our arrhythmias. If you have a refractory VFib that's not responding to your defibrillation or your pulsus VTach, any of the stable live complex tachycardias is when we're gonna look at giving the antiarrhythmic. And for that dose, you give your 300 milligrams initially, and then you can follow it up with your 150. Or for your infusion, you'll do 150 of IV over 10 minutes. And then you want to keep them on a maintenance infusion after that initial bolus has been administered. And then we have our lidocaine, which is our alternative antiarrhythmic. It is also indicated for your stable wide complex tachycardias, such as a refractory VFib and a pulsus VTach. Your dose is initially 1 to 1.5 mg per kg, and then you half it. Whatever you gave, if you gave 1 milligram per kg, your first dose, then your initial or your secondary dose will be half of that. Or if you gave 1.5 mg per kg, you give 0.75. And that's every 5 to 10 minutes for a maximum of 3 mg per kg. So if you have a 100 kilogram patient, you don't want to go over 300 milligrams on their dosing.
Amio can also be, we have it as a third line agent. I actually went to look to see, because I remember in the ICU, we would do it a lot for our AFib with RVR.
Yes.
It's as a third line agent for us on our protocol. So I don't know if you guys have it as well, but amiodarone can also be given for AFib with RVR along with your ditalzin and your metoprolol to kind of bring that heart rate down.
Really?
Yeah, that help it gets more synchronized.
Which I know in the ICU setting that was a lot of the times when I gave amio was more for AFib with RVR than anything else.
Mm-hmm. Yeah, and for a long time, we did not have our cardizem
Yes.
in our formulary medications in the helicopter or the airplane.
Mhm.
So amio was our first choice of drug for AFib RVR.
I think that's because we had to tell us that. And I
Yes.
think under Baxter's protocols, you guys having your own. So I think that's.
And I think
probably-
that goes back to who your cardiologists are.
Yeah.
So because since I did Baxter ICU,
Mhm.
most of the cardiologists, with the exception of Dr. Camp, I think it was Dr. Camp that liked the lidocaine better, but the rest of them were more amio.
Okay.
So
So that's good knowledge. So our atropine for our symptomatic bradycardia, this is the first drug we want to consider. We're going to give them 1 milligram every 3 to 5 minutes, just like the epi. And I like with the ACLS, a lot of the doses are similar, but that could also be a hindrance because you could get them confused. You know, you'd be thinking amio, atropine, oh, it's 1 milligram per kg or 1 milligram every 3 to 5 seconds, and that's absolutely not correct for the amiodarone, of course. So that's why it's always good. I'm never too good to pull out my phone and look at my protocols for reference. So
Now we have a cheat sheet.
yeah, yeah, we can print that off. Yeah, so that's a something to consider. And so we're gonna give them that 1 milligram every 3 to 5 minutes till we've reached a max dose of 3 milligrams total. And then it might be ineffective in your high degree blocks, such as your second degree, type 2, your third degree. We're probably gonna be looking at pacing and a infusion, whether that be dopamine or epinephrine, if they have some of those much slower heart rate rhythms with a block. Just a little bonus quiz. What other patients might be resistant to the effects of atropine?
When maybe on a beta blocker.
Well, yeah, if they're beta blocked, for sure, that could definitely make them less responsive to the.
I want to say vaso. I'm gonna get this wrong, but no, it's either vasodilators or vasoconstrictors. No.
No, not for sure. This is just like a little bonus question that lives in my head rent free. It's patients who've had a heart transplant.
Oh, really?
Yes, because of where the vagal nerve is. So you were on the right track with your vasoconstricted, vasodilated, but whenever they have a heart transplant, where the vagal nerve is typically innervated in your native heart, that is not re-innervated whenever they do the transplant. So it's not going to react to the atropine.
So how long does it take? Or does it ever come back?
I don't think it ever comes back.
Really?
Yeah, I've always just been told that it just is not effective. Atropine will not work on people who've had a heart transplant.
So if you have a symptomatic or asymptomatic bradycardia and you give atropine, it's not gonna.
Yeah, if they've had a transplant, yeah. So you're just really gonna have to go, pacing is gonna be your best friend in that
That's it.
situation.
Okay.
Yeah.
Wow.
Which pacing, I feel like was one of those things, kind of like when we talked about needle decompression a couple of weeks ago, is if you don't use it and you don't use your monitor and you don't click your buttons and actually look at what it looks like on your monitor to do it, it's going to be one of those things that it's harder to do in the moment. And so I think that's one of those skills you need to try to make sure that you understand how to do it with your equipment. And that way, so when you have to do it, you know it.
Yes.
Because I honestly had paced one time ever in the ICU. I have yet to have to do it in the aircraft. And it wasn't until my last ACLS class that I went to help teach that we had a program that she used, and it basically mimicked the Zoll monitor, and we could do a simulation of clicking and pacing a patient. So you could see how you do capture and how you do your amplitude and what it actually looks like when you get these things. It's called DART. It's for iPad. It's not for
Of course.
Android.
Of course.
I know. It's only for Apple.
Yeah.
But it's a little pricey, but it is definitely worth it, especially if you're an AHA instructor. It was really, really helpful. But
Yeah.
I'm not getting rid of my Android.
I know, me neither. Latricia's the one that had it, and so we went through it. But
Yeah, I haven't seen that.
it's really good to kind of know, because especially with you guys being in the back of a truck by yourself, it's not like you can look at your partner and say, "Hey, have you done this?"
So another thing, if you're wondering if you've got effective capture, you should start seeing your perfusion increase on your patient. The color's gonna get better. Their heart rate obviously is gonna come up. They're gonna just look like they're not quite as close to death as they were. You're gonna be able to hopefully palpate that peripheral pulse because your blood pressure is gonna be responding and coming back up out of hopefully out of that shocking state. So there are tools like that. The electronic tools are great, but don't ever forget to go back to, what we were initially taught. And I always remind people, always check for your pulse peripherally if you're checking to see if you have physiologic capture from your pacer. Because if you're feeling up here, they're carotid, every time they pace, they kind of jerk a little, and you could mistake that for pulse. But also, if you have this peripheral pulse, you know that your blood pressure is climbing enough to probably, 90, so that you're having that peripheral perfusion. So it gives you an idea of your capture and your patient status. So I always hit on that topic. We will look at our dopamine. That used to be the drug of choice for all the septic shock, cardiogenic. I mean, it's still pretty good for the cardiogenic, but septic shock, they would all get the dopamine. And in the last 8 to 10 years, it's gone back to Levophed. I know whenever I started nursing 16 years ago, it was Levophed, leave them dead. And so whenever Levophed came back out, I was like, what? We're going to give them Levophed? What? Are they really that bad? And as it turns out, it's the more effective choice as the.
Well, I think that's probably one of that, and probably lidocaine is probably 2 of the most underutilized
Yes.
in our
So,
drugs.
whereas I have not ever had good experiences with dopamine. It's like almost every time I have used dopamine, I have had them have some type of antiarrhythmic reaction, like
Because
notice
they
on
have
the
the
AFib.
tachycardia.
Exactly. So
Yeah.
I've always enjoyed my levo because I feel like I can titrate a lot better. However,
Yes.
I'm excited
Yeah,
because we
more
have some edited things now.
Yes,
So
our
we
Neos
have
and
some
the
Neo and things coming down the pipe for us. So
And one important thing to remember, if you have a patient on dopamine and you add Levophed, or if you're gonna transition them to Levophed, don't just pull the dopamine off of them. You have to titrate that down as well, because they can have like a refractory, they can go into the refractory bradycardia, hypotension, if you just pull the dopamine off because of the alpha and beta effects.
yeah, because they don't exactly cross evenly over. So as you lower one, you'll start to raise the other.
So
until
do
you
you
find
run
the
it the
right
same
one.
line, or do you have to get a
I
new?
think you got it.
Okay.
I've got and I didn't realize this till the other day. I have a compatibility chart I can send you. It's just one small sheet, and it's mostly your ACLS or your cardiology drugs.
The ones
Okay.
Jake made.
I guess it's in the clipboard. I didn't find it
Yes,
till
yes,
yesterday.
Jake. I
I
think I
cleaned
have it
stuff
in my
up.
email, I think. I
If you
can
do,
send
then
it to
just
you.
email it to
It's
her.
interesting what you find when you clean.
Oh,
Yes.
yeah,
Yeah.
I'll tell you later. I've been through, my OCD kicked in the base house.
Yeah. Yeah, well, it looks amazing, so
Well, thanks.
keep it up. So we can infuse that dopamine 2 to 20 mics per kg per minute. Our epi infusion was just mics per minute. So some of these are weight-based, some of them are not, and always just be mindful of what you're given and the correct dosing. So our adenosine, we are gonna give that for SVT. That is our narrow complex tachycardia, whereas the others were for our wide complex tachycardia. We're gonna give that initial 6 milligram rapidly, and we're gonna follow that with at least 10 to 20 mLs of normal saline flush. And where do we want our IV to be if we're gonna give adenosine?
AC or higher.
Yeah, we want it up as close as possible, as proximal
And why is that?
to the heart. And why do we want that?
Why?
Yes,
Yeah.
you want it closer to the heart, so it's actually.
Yeah.
That's what she was
Because
saying.
it's half-life.
Yes, its half-life is just expendable, like it's just gone. That's why we.
So
give
don't
it
start at the
rapidly.
toe.
No, yeah, by the time it gets up here, it'll be gone.
Mhm.
So, yeah. Get that high IV site that's most proximal to your core and give your rapid push, follow it rapidly with your flushes. And then if there's not a response, we can repeat it and we're gonna double at that time. And to remember that This is adenosine, so we're gonna add to it. We're gonna add 6 and 6, and that's gonna be 12. And then I can't remember how to remember the amio. But if you can just remember add adenosine, you're gonna add them together. Whereas the amio, you're taking away. So that's one way to remember your dosing for that. Okay, what is that beautiful rhythm we got going on there? Torsades.
Polymorphic mutant.
Yes, the polymorphic. It's arising from different parts, different areas of the heart. And so we're going to give our magnesium for that. It's important to recognize this quickly and to give the magnesium because that is the true indication that, of what can be helpful to convert your patient out of the torsades. And then we can also give the magnesium for hypomagnesemia as well.
I'm glad you can pronounce it. I mispronounce it every time I say it.
It was definitely a tongue twister. So we've got our calcium chloride versus or our calcium gluconate. The dose is the same for these, but the volume is different to achieve 1 gram. So make sure you're mindful of which type of medication you have, whether it be the chloride or the gluconate. And we can, if we know that our patient is hyperkalemic and they're, getting worse off, more symptomatic, headed towards a cardiac arrest or actually in cardiac arrest, we're going to want to give them that 1 gram. Or if they're hypocalcemic or have a calcium channel blocker toxicity. When's another time that we might want to give calcium?
Trauma.
Yeah. Our trauma patients gotten 3 units of blood.
Your blood transfusion.
Yeah, so blood transfusions, make sure we are mindful of that.
So if you pick them up out of this ER and you're fixing to go somewhere and they've already had 2 units, that may be something you want to be mindful to ask your docs, hey, have you given them some calcium?
Yeah. We're gonna ask them what's their potassium look like, and then you can evaluate their EKG as well. And if you're seeing those peaked T waves, you could bring it to his attention, say, hey doc, I'm seeing this. Do you think that they might be getting a little hyperkalemic? Should we administer that calcium, help stabilize that? Because we don't want an irritated cardiac muscle on top of trauma, blood loss, resuscitation, all that stuff. We want our patient as stable as possible.
Because
Okay.
you guys are the ones doing the transport when the weather's bad.
Yeah. So what's the science behind a hyperkalemic? Because that's potassium. And giving calcium. What's the science behind that? Does one
It helps to move the potassium back into the cells.
so anaerobic versus
I don't know if it has a.
It's similar
course
to
it
your
is.
sodium and your potassium.
Yeah.
It's one,
it's the
It-
barrier?
yes, it's the way the
Yes.
barriers go.
Okay.
So if one's too much over there, but you don't have enough over here, you give some of the calcium to make it.
Okay.
And it's a negative ion,
I think so.
and
think
so it helps
Okay.
to
Potassium's a
stabilize.
So
positive,
it has to do
calcium's a
with
negative.
Osmosis.
Yes.
Okay.
Yes.
Yeah, and
Your
so,
electrolytes and your balances there.
yeah, because the potassium can be aggravating, and that's what destabilizes that cardiac muscle
Okay.
and can cause an arrhythmia, tachycardic arrhythmia. So, another pop quiz thing that lives in my brain rent free, calcium chloride is, I believe it's 3 times more bioavailability than the gluconate. It might be more than that. It's significantly more bioavailable, even though you give 1 gram of chloride versus 1 gram of gluconate, but the chloride might be more effective whenever it's administered, just because of how the body uses it.
So I'm tickled at her because she's like, the things that live rent free in my
Yes.
head. And we had a debate going on this one. It shows our intelligence level of what was Bugs Bunny's girlfriend's name.
Oh, yeah.
This is like a 5-minute conversation that we had, and everybody was wrong.
Is it not funny?
No, she has a name. I wanna say Daphne, but that's not correct.
No, that's the
Doug.
Doug.
That's
That's the
Doug.
Doug.
Babes.
Babes. That's the Doug.
Well, they said Betty,
Or is
and
that-
Betty isn't right.
No.
Did anyone
Buddy.
Google it?
Oh, yeah.
Yeah.
It was Lola.
Lola.
Yeah.
You are correct. You are absolutely correct. Moving on, because I don't know.
We
what
know what everybody's doing on their off time. It's not studying, that's for sure.
So,
I think I'm the one that proposed it.
I think that's a great question. Those are things to know.
There's a little bit more context. She has a giant bunny.
Oh,
That's how this goes.
so, like a real one, a live one?
Yeah.
Yes.
Is he Bugs Bunny or a Lola Bunny?
It's Mabel.
Mabel?
Mabel the
So that's
unstable.
a lady bunny?
I was attacked last night, and so that's kind of how the conversation went.
The bunny is like your cats. It's not in a cage. It's
It's
like
her
just
baby?
wild in
Oh,
the
I love
house,
that.
has a litter box type.
Yeah, and
Yeah.
they're easy to train,
Mhm.
so.
Yeah,
She'll whip the cats.
she will, and she attacked.
She's big enough.
But she didn't attack me. She crawled into bed with me, and we were. I don't know if she watched the CPR video and decided she landed right on my chest, and I was
gosh.
trying to get her off, and it scared her, and
Oh, Lord, she's a big girl. Oh, my. That knocks the breath out of you. I have a 20-pound cat, and she likes to step on my chest, and I'm like,
make biscuits.
Stop.
Yeah.
So, okay, let's get through the rest of these so we get our OB. Because I feel like this has gone so well though. Y'all made me much less nervous.
I told her to not worry.
Yeah. So, our back arm, we want to give that only when it's indicated. It's not like 10 years ago when we used to give it to everyone in cardiac arrest. If we suspect a severe metabolic acidosis and we want to reverse that, then we can definitely give them the AFA bicarb. And then hyperkalemia, we can also give that along with our calcium, and that is just another balancing act of the positive and negative ions. And then for a TCA overdose, sodium bicarb is our go-to for that. And I meant to mention a while ago for a beta blocker overdose. You know what you give? The magnesium.
Oh, okay.
Yes,
How much?
I can't recall right off the top of my head. Glucagon, actually, it's glucagon. It's not magnesium.
Oh, okay.
Yeah, so you give glucagon for, but I think there's something to do with magnesium for that as well. But beta blocker overdose, it's glucagon. But for our bicarb,
They do.
yeah, we don't carry it
We
in
don't
the
anymore.
aircraft. No, but you could, if you're picking up from a sending facility, you might say, we don't have any of that. Can we please borrow yours?
We do that.
Yes.
Oh, do you?
I vote to take stuff. So before we go away from the bicarb, it
Mhm.
said severe acidosis. What is something that you guys will maybe run into that you would be transporting that could be a severe acidosis?
Respiratory failure.
True. What else? Your traumas.
Mm.
Your traumas and heavy blood loss. So if you have a traumatic arrest and you've tried all the other things, try an antibicarb because they are probably acidotic.
Okay.
Yeah.
So that flight that I kind of had mentioned the last time that we had the 2 aircrafts and we did the double chest tube. This guy, that is what we ended up giving him that gave us that little bit of hold on to get him to somewhere to stabilize.
The light bulb just went off of why you get bicarb during code.
Yes.
Why
Because
would
they
you give it
become
in trauma?
acidotic.
Yeah.
What happens if there's CO2?
Yeah.
Tons,
Yeah.
They can't all
I
flow.
do have a question about that, because you just said that you don't give it for every situation. So if you've been working, so let's say I'm not suspecting severe metabolic acidosis, and I've been working this code, and I'm reaching the 15-minute mark of, I'm either gonna have to call my med director or, just keep writing, maybe they'll come back. I don't know what the other option there is. Can
I'm
I go
glad
ahead
I'm not
and
the
give
only one.
somebody in my card, or am I
Usually,
too far
yes.
late?
I mean, I would have that discussion with your medical director.
Okay.
And I would also see what your protocols say.
Because some of the people over at so I've worked both places, so some people over at Baxter Health, they get bicarb for every code, but they're also older, they're older medics, and so
Yeah.
that would be that older mentality. I've never heard them be told not to. Well, everybody who's became a medic, when I became a medic,
Yeah.
we don't use bicarb in every code because it's not what we were taught. We were taught,
Mhm.
this is
I think it's
Right.
always that it's,
What is gonna hurt?
they're already dead.
Yes.
And where's your,
Right.
where's your
That-
acid level at this point? If they've been hypoxic, if they're hypoxic, what is their acid level gonna be like? They're gonna be high, so they're gonna have acidosis. If they're traumatic and they're bleeding and they're losing blood,
Okay.
what are they gonna be?
So this is give it more often than not at your 10-15 minute mark if you're not getting it back.
If you're not getting
So-
results of some kind, you know,
Oh,
you've
yeah.
done the epi,
I
you've
agree
done the
because I
things.
understand the signs, the
Yeah.
acidosis.
Yeah. Are
Um,
you looking at your capnography? Is that how you're making that decision? Cause I mean, if they're
Um,
dead,
during-
then.
But
During your code, you're gonna have some capnography, but a lot of it, you're watching, why do you watch your end-tile during code?
To see if we get ROS.
Yes, and then also your compressions,
Yes.
you know, that tells you how you're doing your compression. So you could,
Okay.
because it's showing you your perfusion, that's the word I was looking for. So you should have some kind of reading on there.
Okay.
Of at least
But
10.
it, yes, which,
Cause that indicates that you're doing effective compressions.
Okay.
But if it's just like static, they're not gonna be breathing, so you're not gonna have a readout all the time, but if you drew that OBG, their CO2 would probably be elevated.
Okay.
So, but like she said, if you have that ROS, then you might see the abrupt jump.
Yeah.
But I think that the sodium bicarb is appropriate just because of all the acidotic things that are going on.
Okay.
And like you said, they're not getting better. But I would definitely talk to my medical director with that and, or just education and see what their opinion is.
Okay. Thank you.
You're welcome. So some of the tools, what are some of the things we use to look at our heart rhythm and cardiac conditions?
cardiac monitor.
Yes.
Lab values.
Yes. The EKG, of course, it's important to be able to read an EKG appropriately so that we can hopefully interpret the big ones. We don't want to miss a full-blown, like blatant STEMI. Sometimes it's easy to miss ones that aren't quite as obvious, but we need to be familiar with identifying what does normal look like and how does this one compare to normal so that we can anticipate the course of treatment. Obviously, we want to get blood pressures and reassess our vital signs, blood pressures, pulse ox, all of that throughout the course of our transport. And that can tell us if our interventions are working and if our patient's getting better, hopefully better, not worse. Pulse ox, of course, goes along with your blood pressure, your heart monitor, EKG. And we must be able to understand them, know the normals and for different age groups and do what we can to correct the abnormals so that our patients' outcome can be optimized. A few more pharmacology bullet points. More common medications that your patient might be on at home is, the beta blockers, ACE inhibitors, and your anticoagulants. I think that it's important to mention the new anticoagulants that they're on these days are not as easily reversed by the vitamin K. They might have a specific reversal agent. It's been, I feel like 100 years since I worked in a hospital.
Can you tell me more about that? Or y'all probably been.
We don't know,
More
or I don't, at least,
There's,
do you know which one?
I think one that starts with an
Eliquis.
Eliquis? Yes, it has a specific reversal agent, does it not?
Did, you guys talk about that?
I think so.
Last
I
week.
think
Yes,
so.
they
I
did.
do remember this.
There were two,
I don't remember. what it is.
Eliquis and warfarin was like the ideal.
Yes.
Yes,
Is that
because
your vitamin
easily-
K?
Yes.
Reverse it, your.
Yes.
Okay, but then it's also like if your blood drawn every couple of weeks to make sure you're in a good level, therapeutic level, and
Mhm.
I think that's why the push is to go. to
That,
these
and
newer
it
agents.
was more likely when they fell and different things, like
Yeah.
they could have that toxicity
Mm.
and then spontaneous bleeding and
Whereas I don't know how they think that these new agents do not pose those risks,
Yeah.
but I'm not a pharmacist, I'm not a cardiologist.
And the other
so-
thing is there are so many out there, and unless it's like in the name that I recognize, sometimes I'm like, what is that? I have to look it up and it's like, oh crap, yeah, they are in a blood thinner.
Yeah,
So
so just be mindful and try to get a good, history from your patient as to what they're on, what they're supposed to be on. Did you run out of your Coumadin last week? Oh, and now you can't talk and you've got slurred speech and arm weakness? Oh, okay. Yeah, so make sure that you try to get as good of a med list as you can and have an idea, like you said earlier, if they're beta blocked, they might not respond as appropriately to your atropine or dopamine, whatever you're trying to do to correct the heart rate.
It's not TPA, what is it, what's the other one?
TXA.
TXA is the
Yeah, TNK
top-
is what
stop
they
the bleeding.
replace. Yeah.
TNK is let's let them bleed.
Yes.
So I don't know how to pronounce either one of those.
The Fibertide and this. This, I've seen this one.
I haven't seen that one. I heard the other one. And then of course Plavix is clopidogrel. So
The book are kind of right on that.
it took me working in the clinic and having my nurse practitioner prescribe it 100 times for me to finally do it. Phonics was a thing.
Yeah.
So, whenever we're given any of these medications for our cardiac patients, make sure that we can understand and recognize side effects if they have any bad reactions. And we're able to immediately recognize a contraindication if we should not be giving a patient a medication if they have an underlying condition or an anaphylaxis allergy to it, or if they take another medication that's, hugely contraindicated with the administration of whatever. And there's usually, if there's severe contraindications, those are usually in your protocols, and you'll be able to recognize those. And so just be aware of all that so that we can reevaluate our interventions and make sure that we're giving them appropriate doses and management. So we're gonna look at a case study.
Are you asleep over there, Chris?
Just listening,
Do
keeping my mouth shut. and just
you have
listening.
any input?
Just keep my mouth shut and keep listening.
So
There's actually some more in that second drawer over there. In that, patient.
we got called out for a 67-year-old male. He has this history of hypertension, coronary artery disease, congestive heart failure. He called us because he had a sudden onset of severe shortness of breath. It started about 30 minutes ago while he's lying down, and now he just feels like he's drowning and he cannot speak in full sentences. What are we thinking might be going on with this guy?
Fluid build up in his lungs.
Yeah, especially with that history. What are we gonna be looking for with our assessment?
Listening to his lungs.
Yeah,
For those crackles and rails.
Of course, yes. Are we gonna see anything systemically or peripherally?
And pay attention to your map.
Yeah, yeah, map is always, I haven't mentioned that through this whole thing, but map is a good guidance of
What
care.
was pushing map? A stroke, you push map?
Yes.
Map, 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 map.
Yeah, for your cerebral perfusion.
Mhm.
Yeah. So our assessment reveals a patient who is severely in respiratory distress. He's diaphoretic and anxious. Anxiety is hypoxia until proven otherwise. That's just a general rule of thumb
Wow,
I've
okay.
lived with since
How
2018.
did you know?
Yes. So if your patient is super duper anxious and you can't figure out why, slap some oxygen on them and they might just calm down and you fix that whole problem. So his airway is open, but it seems like he's struggling to breathe. He can only speak in 1 to 2 word phrases. We do have those rails and crackles, and it's throughout. It's dispersed through all of his lung fields. He's breathing 32 times a minute. You can see his accessory muscles. Tachypnic, of course, and he's 84% on room air. So as you got all of your monitors on him, your blood pressure pops up and it's 220 over 110. Your heart rate is 110. He has weakness for his peripheral pulses and his extremities are cool.
Pump problem.
Yes, he has a pump problem. So he's pale diaphoretic. We already talked about his history and you can see there his medications. So
Is he compliant with his medications?
It's right there on that path of medical.
Non-compliant.
Okay,
no,
non-compliant, okay.
so what are we thinking? We're thinking it's a pump problem, it's a fluid buildup.
Is there a temp?
No, he was not on permit.
Okay.
Yeah. So we suspect that he's got a flash pulmonary edema. So he's in a decompensated heart failure. What are we gonna do for this guy?
Positive pressure inhalation.
Yes. So that's gonna help open everything up, help push everything out. So that's gonna assist his respiratory drive and his effectiveness of his respirations. What is a medication infusion specifically that we can start to help his preload, decrease his preload and afterload?
I consider Lasix.
Okay, yeah, that would be okay too. What is another one? Oh, well, I clicked it, I told you. So nitro infusion, yes, you start him at 5 knots and titrate. I have seen this turn a patient around in like 3 minutes.
It'd have to be tablets for us.
Oh, yeah.
Yeah, they don't have.
Yeah.
We got this a little bit. She's got some room up there.
Yeah, you can give the
Oh, okay.
sublingual.
See, I don't read very well.
As long as your blood pressure can support it.
Yeah.
Yes. But I love the IV nitro infusion for this, along with the positive pressure, because the positive pressure, it's gonna increase your intrathoracic pressure, and so that could decrease your cardiac output even more. So, but we do want to support his respiration, so CPAP for sure, and then a nitro infusion is beautiful. If their blood pressure can you support it, and all you have is a sublingual, that can be helpful as well. And like I said, we want to reduce the preload and afterload so that we decrease that pulmonary congestion. You said pump problem, so our pump's getting backed up, and as it gets backed up, it's less effective to pump out, and then it just becomes a
Regurgitated.
yes, the
Yeah.
problem is just compounding itself. And like you said, Lasix, you can go ahead and give a bigger dose if they're not already taking a diuretic, and then just a standard 20 if they are. Or vice versa. If they already take one, you can give the 40. If they don't, just give the 20. They might be more resistant. Once again, the morphine, they say that it's a little bit controversial. It could worsen the respiratory depression, their cardiac status. And you want to give that low and slow dose.
So a question on that. What was his respiratory rate initially?
32.
So would that be,
Well, you could knock out his drive completely if you give the pain. Because you know,
Because you think about how labored he was, how much work of breathing he was
Yeah,
already.
yeah, the accessory
So,
muscles. he's
You
Okay.
give that
84%.
and it ends up being too much to depression.
so it would
needs-
still be contraindicated?
Yeah, you would just
I
want to
wouldn't
be
say
really
it's
careful
caution,
with it.
not necessarily contraindicated. I mean, I might consider it because of the way that it does help open the airways. But at least then knowing going into that caution, what do you already have in your toolbox that if it does happen, what can you do?
Yes. Yeah, it's just
There you go,
a
smoke some
extra
plastic.
consideration.
Yeah.
So if you completely knock it out, you can put a tube down and breathe for it.
Question about that for y'all. Have y'all personally experienced a CHF patient that you have on CPAP go unresponsive?
I have walked into a transport to an unresponsive female on CPAP. She was like 25, 26 years old, small. So she was being ventilated with these, it's probably BiPAP. I think it was BiPAP. But she had no respiratory drive. She did not awaken to stimuli. We intubated her at the bedside.
So
But
then
she,
that's my next question is, did y'all have to use any sort of medically assisted drugs to intubate her?
So,
Because that's one of my big
yes.
concerns with CPAP.
So you
Yes.
think about why do we use drug assisted intubation?
So they don't vomit.
So they don't vomit, so their vocal cords
Yes.
are paralyzed, so we don't damage those.
Yes.
So those are your reasonings.
and
So
just because they might not be arousable to verbal or painful stimuli,
they may
they
still
can
have a
still
gag.
hear you. They can still remember the situation. They can stop the gag reflex. So you want to make them comfortable as much as their hemodynamics can support it and paralyze them so that you don't have that vomit.
So if you don't have accommodate and rockaronia, you really can't intubate these patients because
You
they're
can if it's a crash airway.
Yeah,
it's a crash.
You're
That's-
just going to,
that's where
Yeah.
your decision's gonna have to be. Is this enough that I can crash airway because I don't have the ability? However, what you do have is the ability to call, and that is another reason that you can call us.
Okay.
If your protocols do not allow you to give the care that this person may need,
Mhm.
that's another reason you can call. So,
Okay.
because whenever we chart, we will chart those reasons. RSI not in protocol for local EMS,
Okay.
you know, so that
Yes.
gives us a reason of covering why we went.
Okay.
So,
Cool. So a crash airway, I would just go ahead and intubate. I'm not needing to use any Versed or anything like that, just straight
and
intubation.
when I consider crash airway, I'm normally thinking this guy's I'm about to code him.
Okay.
Yeah.
Like he still has a pulse, but he dead.
Okay.
So that's my crash airway.
Okay. that makes
Anybody
sense.
else, they're getting drug
He's
assisted.
seen Jesus, he just
Yeah.
hasn't shaken his
Yeah,
hand.
they haven't shaken his
He's
hand.
looking at him through the window. He just hasn't opened the door yet.
Okay, cool. I've heard that phrase. crash
that
airway.
you,
Yes.
And a lot of times, crash airway will still involve a paralytic,
Okay.
especially if you get in there, you lift up and they're clenched, or you're not able to visualize and whatnot, and then you can get that paralytic. But it's really just like, hey, we're crashing, we gotta put something in there. So, yeah. So during transport, we want to reassess our SpO2. We want to make sure that that's improving with our positive pressure and the nitro. We're shooting for 90% greater than or equal to. We want to make sure that our blood pressure doesn't bottom out after we give the nitro. So we don't want to have to turn around and support that blood pressure after we gave the nitro to bring it down. So be just judicious with the administration, especially the sublingual tablets or spray, because that's a much larger dose than what you give for the IV. It says 211 for
That does say 211.
check out their respiratory effort and rate And hopefully he's gonna be able to speak in a sentence rather than, just short phrases and gasping in between words. What's your EKG for any evolving heart rhythms or ischemia that might occur? And repeat listen to those lung sounds. We want to make sure that they're improving with our interventions. So for our report, we want to call in and I like NIST. It's the mechanism of injury or chief complaint, your interventions, your symptoms, and your transport decision. Why did you take them here? Transporting to a PCI facility for PCI, transporting to a stroke facility for whatever, you know. So we've got our 69-year-old male. We suspect he had flash pulmonary edema. He had sudden dyspnea. He had orthopnea. He couldn't breathe while he was laying down. Crackles diffusely throughout the lung fields. Hypertension. We got him on CPAP at 10 centimeters of water, and he's,
Sorry.
it's okay. I got so distracted. He's tolerating that well. We've given some sublingual nitro times 3, and followed that up with IV nitro. We started that at 5 mics per minute. And then we went ahead and gave him 40 milligrams of Lasix. His 12 lead showed no STEMI. It was a normal sinus tach. I think he's tachycardic. He called us for dyspnea, and he was hypoxic when we arrived, hypertensive and tachycardic. So we're about 5 minutes out. If you want to notify the ICU or PCI, notify whoever for this specific event. In this case, it's the CHF exacerbation.
So your MIST format there, I've never heard of MIST. Is that nursing?
No.
I actually never heard of it either till I saw her slide. I was
Okay.
like, oh, that's
Well, I was
cool.
thinking, okay, well, that's kind of feminine, and nurses, you know, EMS is more, you know, aggressive and masculine, so we have soap, and when I think of soap, I think of like prison, you know?
I just realized it.
It's hilarious. Or literal, like you said, like Campbell or chart, you know, but
No, I actually heard this the first time at the Arkansas EMS conference, like 3 years ago, I believe it was. Yes, 3 years ago. And it makes a lot of sense. I like it because it's just an easy mnemonic. Because just like whenever I'm trying to talk with people in the hallway here, whenever there's people on the radio, I'm like, I don't know what my patient is, but I'm coming to you because they are dying. Like that's literally how I feel sometimes. So I always try to just make a short synopsis of this, and I'm able to tell them who I've got and what we're coming.
I just remember that video. I've sent it to you 48 times. Patient's not done. Be there in 5 minutes.
Oh, that's okay. I've got one to share to you later when we're done. CJ said it to me. It was great.
So, your key takeaways: early recognition, early intervention. For that guy, he got CPAP and nitro. They were essential for him to improve his oxygenation. We did not want to give him excessive fluids because that could have increased his pulmonary congestion. Careful monitoring because we don't want to bottom out his blood pressure with that nitro. And we got a rapid transport to a cardiac capable facility. And then in conclusion, we all need to understand our cardiology principles and our emergency response protocols.
She's so delicate when she says that.
Our principles, our diagnostic tools, and our pharmacology.
She is. She's great. Really.
Thank you. I don't feel like, because I'm so nervous in my head. I don't know if y'all could tell it or not, but so.
You know for years.
So that's all of it. And then we've got OB.
Yeah,
coming up.
but we take a little break.
Yeah, we're gonna take a little break. I gotta make a phone call. HR calls, that's never good.
This might be my last class I ever got to take.
No, ma'am. No,
That's where
ma'am.
the trauma is, right there.
When this one comes up,
The Northwest one?
they got a bunch of OB on that.
Do
Yeah,
they?
we just